Hello everyone. Today we'll discuss a practical clinical approach to proteinuria. Stay till the end to understand how the mechanism guides the diagnosis. Proteinuria is not a final diagnosis. It is a clue from the kidney. When we see protein in the urine, the right approach is to confirm it, measure it properly, look at the urine sediment, and then decide where the protein is coming from. The first step is confirmation. One positive dipstick does not always mean chronic kidney disease. Proteinuria can be temporary. So repeat the test, preferably using a first morning urine sample before labeling the patient. Once proteinuria is confirmed, the next step is to quantify it. ACR is useful when we want to assess albuminuria and kidney risk. PCR gives an estimate of total protein and becomes helpful when non-albumin protein is suspected. A 24-hour urine collection is not needed for everyone, but it can be useful in selected cases. Albuminuria is divided into A1, A2, and A3. A1 is less than 30 milligrams per gram, A2 is 30 to 300, and A3 is more than 300. This matters because albuminuria, along with GFR and the underlying cause, helps us estimate kidney and cardiovascular risk. Now think about the mechanism. Proteinuria usually comes from one of four patterns: transient or functional proteinuria, glomerular proteinuria, tubular proteinuria, or overflow proteinuria. Once you identify the mechanism, the causes become much easier to organize. Transient proteinuria is usually mild and temporary. It may happen with fever, exercise, dehydration, acute illness, or hemodynamic stress, such as heart failure. The important point is that it often improves when the underlying trigger settles. Orthostatic proteinuria is a classic benign pattern, especially in adolescents and young adults. Protein appears in the urine during the day when the patient is upright, but the first morning urine sample is usually normal after lying down overnight. Glomerular proteinuria means the glomerular filter is leaking. Because albumin is the main protein crossing the damaged filter, this type is usually albumin predominant and can be heavy. Always check the urine microscopy, because hematuria, dysmorphic red cells, or casts point toward active glomerular disease. Glomerular causes can be primary or secondary. Primary causes include minimal change disease, FSGS, membranous nephropathy, IgA nephropathy, and C3 glomerulopathy or MPGN pattern. Secondary causes include diabetes, lupus nephritis, amyloidosis, infection-related glomerulonephritis, hepatitis B, hepatitis C, HIV, and malignancy-associated disease. One important correction: amyloidosis is best thought of as a glomerular cause of proteinuria. Tubular proteinuria is different. Here the problem is not mainly the glomerular filter. The proximal tubule fails to reabsorb small filtered proteins, so low molecular weight proteins appear in the urine. This is usually less heavy than classic glomerular proteinuria and may be seen with Fanconi syndrome, tubulointerstitial nephritis, acute tubular injury, drugs, or toxins. Overflow proteinuria occurs when too much small protein is filtered through the kidney. The tubules cannot reabsorb all of it, so it spills into the urine. Think of light chains in plasma cell disorders, myoglobin in rhabdomyolysis, and hemoglobin in intravascular hemolysis. A key point is that the urine dipstick mainly detects albumin, so non-albumin protein can be missed. Some findings should make us more concerned. Nephrotic syndrome, proteinuria with hematuria, red cell casts, a rapid fall in eGFR, resistant hypertension, low complement, or systemic features suggest significant kidney disease. These patients need urgent evaluation and often early nephrology referral. So the practical approach is simple. Confirm the proteinuria, quantify it, check urine microscopy, assess eGFR and blood pressure, identify the mechanism, search for the cause, and refer early if red flags are present. Proteinuria is a clue. The mechanism guides the diagnosis.